Yes, we can see your slides. Perfect.
Okay.
So shall we start now? There?
Yes, sir.
So good evening, everyone. Respected Irani madam and all the participants. Today, Sunil is not here. He's unwell. But on behalf of the Maharashtra State NNF, we welcome you all for this webinar. I think we all have realized that newborn care is becoming more and more expensive. And today, the need of the hour is to minimize the costing and give good quality care. And we all understand that in today's difficult times where expenses are mounting, I think we all need to provide cost effective newborn care. So to have with this topic, I thought we should have two people, one from private sector and the other person from the public sector. And we indeed have two great speakers today. We have Dr. Anitha. She is associate professor at GS Medical College and KEM Hospital, Mumbai. Dr. Anitha is uh, exceptional neonatologist. She has trained in Australia and she has a lot of publications on her name. And she will give us the public sector approach in terms of how they manage the expenses and what is the message that we all need to remember. And we have Dr. Deha Pandya, who has done DNB neonatology from KEM Hospital, Pune, and is currently working in Pune at MGM Hospital. So I think Deha will give us the perspective about how the practitioners and in the private sector look at cost effectivity and how we could make newborn care more quality efficacious and minimize the expenses, because in today's time I think that would be the way forward in terms of giving good quality care at affordable price. So without wasting much time, I now hand over the proceedings to Dr. Deha Pandya, and after Deha finishes, we would have Dr. Anitha to give us a complete perspective on cost-effective newborn care. So over to you there. Thank you very much for participating in today's webinar, and even at such a short notice, Dr. Anitha and Dr. Deha consented. So we are really grateful to you on behalf of the Maharashtra State NNF chapter.
Thank you, sir.
Thank you.
Thank you, sir. I would like to thank Dr. Sandeep Kadam and Maharashtra State NNF chapter office bearers for letting me this opportunity. And also, I would like to thank Dr. Kadam sir for the content with help with the content of the talk. So I'll be discussing cost-effective newborn care from a private sector perspective. This wisdom from 1800 still stands true in today's era, especially in neonatology, where importance to administration of medicines as well as intervention was considered important, just like omission or suspension of the treatment or intervention. So as we consider in neonatology, we always say less is more in neonatology, and it is very important to consider this fact. So objectives of this discussion would be identifying major cost areas in NICUs, factors that determine the cost, and potential strategies to reduce cost. So we can identify three major economic areas from where neonatal total costs come from. One is there is a baseline cost associated with all NICU admissions without any morbidities. Then there is incremental cost associated with prematurity related morbidities. And there is third is incremental costs associated with interventions which are done for these morbidities. So this is a real-time bill of neonate discharge, extreme preterm, extreme low birth weight, who is 26 week or 750 grammer, and we can identify major areas from which total bill comes from. One is bed charge, the other is professional charge, third one being laboratory as well as radiological tests that are being conducted during NICU stay. Fourth is other intervention charges in form of ventilation charge, CPAP charge, oxygen therapy, phototherapy, syringe pumps, total parental nutrition, etc., which also contribute to major of the NICU charges. And last would be drugs and medicine charges and all surgical disposables which are being used during NICU stay. So if we try to break up the total cost of NICU stay, 20 to 25% comes from the bed charges and total NICU stay. 15 to 20% comes from medications and that are being used along with the surgical disposables. Around 10 to 15% comes from the investigation that includes laboratory investigation as well as radiological examinations. 20 to 25% NICU charges are because of the therapies like ventilation, CPAP, phototherapy, parental nutrition, etc. And as opposed to common belief, professional fees account for around 10 to 15% of total NICU bill. So like all other ICUs, NICU also bears direct costs as well as indirect costs. Direct costs, as we discussed, all the nursing, laboratory, diagnostic, occupational, pharmaceutical and surgical costs. And indirect costs that are overhead costs in form of finance, housekeeping, medical, biomedical engineering instruments and their maintenance and other non-patient service related costs. This indirect cost also adds to around 20 to 25% of total NICU bills. So what are factors that determine overall NICU costs? So most important being the gestational age. As we can see, overall prematurity itself and lower gestational age without any morbidity in less than 30 weeks, it carries its own higher NICU costs. And when we add morbidities related to prematurity in form of respiratory morbidities, NEC, neurological morbidities, especially in lower gestational age, each morbidity increases NICU costs dramatically and exponentially. So as we can see, late onset sepsis, NEC, BPD, and brain injury in form of PVL or IVH, these all morbidities add to pre-existing NICU cost by nearly 20% to almost to 50%. So the question arises is, does improving quality of care increases the NICU cost? So common perception is yes. If we want to give better quality of care, we need to have better infrastructures and overall the cost of NICU care will be increasing. However, we should also keep in mind that by improving quality of overall newborn care, we are going to improve survival and outcomes and also survival without morbidities, which in long run will reduce NICU costs. So balance between both cost and quality is important, and disconnect between the cost and quality creates a problem. So what are cost reduction strategies that we should consider in today's era? So by improving quality of care of neonatology, we can reduce neonatal morbidities and in turn reduction in length of stay and reduction in NICU costs can be achieved. So all these things are interlinked. So consider this baby A who is 33-week, 2.2 kg baby, male baby, born to gestational diabetes mother and delivered by emergency cesarean section in view of abruptio placenta, and only one dose of steroid could have been given. Baby cried immediately after birth. Baby had tachypnea and respiratory distress, for which baby was admitted in NICU and started with O2 prongs. At 2 hours of life, in view of persistent distress, baby was started with CPAP care. Since baby was requiring nearly 50% of FiO2 requirement and in view of respiratory distress, an X-ray was done at 4 hours of life, which was suggestive of hyaline membrane disease. And ultimately, baby was intubated and given surfactant at 5 hours of life. In view of persistent high oxygen requirement and respiratory distress, mechanical ventilation was continued for 2 days. Baby could be extubated at 3rd day of life with progressive orogastric tube feedings. Baby had persistent tachypnea till 6th day of life. A repeat X-ray was suggestive of good lung volume and resolution of resolving RDS. However, functional echo was suggestive of mild to moderate grade of unresolved PPHA. Full orogastric tube feeding was continued. Oral feeds were started on day 7 of life and ultimately baby was discharged on day 10 of life. So total NICU bill was 86,000 INR and medical and laboratory bill was 46,000 INR. So here we all can identify that what went wrong or what steps could have been taken as a quality improvement measure. So here quality improvement comes into picture where just by using whatever resources are available, prompt and appropriate usage of available resources can reduce overall NICU morbidity and costs. Suppose if the clinical scenario permitted, not in our case, however, if the baby had received full dose of steroid, if baby could have received early CPAP, if baby could have received early rescue surfactant in first 2 hours of life, probably we could have prevented mechanical ventilation, we could have managed with non-invasive ventilation, early resolution of RDS, probably early oral feeds, and we could have discharged baby on day 7 itself rather than day 10. We could have managed to reduce NICU bill by nearly 20 to 30% by available resources only. So here we consider quality improvement as an important intervention to use existing resources to cut down NICU costs. So what are strategies to reduce cost in NICU? They are antenatal, perinatal and postnatal. Antenatal steroid, as we all know, is a very important strategy to reduce NICU morbidity and mortality. And one study suggested that in less than 30-week neonates, exposure to antenatal corticosteroid reduce NICU cost by nearly 40% and reduce NICU stay by nearly 50%. As we all know, antenatal steroid has shown to reduce neonatal morbidities like RDS, need of mechanical ventilation, need of respiratory support, overall NICU stay. It also reduces severe IVH, PDA, and ROP-like morbidities. And it has shown that per patient exposed to antenatal corticosteroids, NICU costs go down nearly by $3,500. Early CPAP is other intervention which is very important during initial phase of NICU management. It has shown that it reduces mechanical ventilation and surfactant requirement by nearly 50%, and both these therapies are associated with higher cost in NICUs. It is also suggested that early CPAP therapy, by which we can preserve FRC, by which we can keep the lungs open during early phase, we can reduce up transfer of the NICU, by which we can reduce overall NICU costs. Early rescue surfactant has been shown to be evidence-based cost-effective intervention which reduces overall hospitalization and overall cost of NICU care. One study suggested it nearly reduced 11,000 of US dollar per patient during NICU stay. So when we consider early versus late surfactant, um, early surfactant group, we would be ending up giving more surfactant to the babies. However, so that cost would be high. However, in late surfactant group, babies who are requiring mechanical ventilation would be more, and that cost would be more. So by and large, early surfactant is an evidence-based strategy to reduce overall NICU cost and overall NICU stay. So to reduce respiratory morbidities, which are most common cause of NICU admissions and NICU bills, and to reduce chronic lung disease, apart from strategies we discussed, other interventions are gentler ventilation, surfactant administration techniques like LISA and MIST, early use of caffeine, which is shown to reduce respiratory support requirement, early aggressive enteral as well as parenteral nutrition, use of exclusive human milk, and less infection. These all strategies reduces respiratory morbidities and helps in preventing bronchopulmonary dysplasias. So human milk is other intervention which is easiest, safest, and best to reduce overall NICU morbidities and related costs. It reduces NEC, total parenteral nutrition requirement, and also reduces time to full feeds. There is reduction in incidence of late onset sepsis, BPD, and ROP, and there are multiple cost benefits, and it is dose dependent. As one study very nicely studied, effect of human milk dose on NICU cost, where less than 25 ml per kg per day of human milk at the time of full feed was compared to 25 to 50 ml per kg per day of human milk feed and more than 50 ml per kg per day of human milk feed. Those babies who were getting less human milk were exposed to more NICU costs, nearly $20,000 and $30,000 compared to other two groups. It is evidence-based strategy to reduce NEC, to reduce total duration of hospitalization. In one study where less than 1250 gram neonates were studied for human milk versus bovine milk, total NICU stay was 4 days lesser in those newborns who were receiving human milk. Those newborns who are receiving 100% human milk diet, average cost saved is nearly $8,000 per infant. So here this is baby B, who is 32 plus 4 weaker, 1250 grams at birth weight, female baby, mother having uncontrolled PIH and deranged Doppler in form of reduced umbilical arterial flows and increased resistance, and elective CS done for the same. Mother had received full course of antenatal corticosteroids. Baby cried immediately after birth and there was no respiratory distress. In view of deranged Dopplers, baby was kept NBM for 24 hours. On day 2 of life, baby was started on trophic feeds, 1 cc too early. On D3 of life, nurse noticed that there was a bit of abdomen distension, 6 cc RT aspirates, yellowish curdy were there. Also, day 3 samples sent suggest of low platelets, 70,000. So considering this, baby was kept NBM. Cultures were drawn and antibiotics were started. On day 4 of life, cautiously 1 cc 4 hourly feeds were started. However, mother's milk was not available. So feeds were not graded up. On day 5 of life, it was decided to go cautiously since this baby was at high risk of NEC. Once to reach half amount of total feed requirement, we would go slow. After that, we can consider 1 cc 8 hourly or 15 to 20 ml per kg per day to reach full feeds. Baby showed improvement in platelet counts on day 5 of life. Blood culture was sterile, but this was considered good response to antibiotics and they were continued for 5 days and then stopped. Ultimately, baby reached full RT feeds at day 10 of life. Oral feedings were tried on day 12 of life, which baby did not accept well, and mother was also not that much confident. Baby reached full oral feeds on day 16 of life and ultimately discharged on day 19 of life. So we also come across such scenarios during our clinical practice where as neonatologists, we should always try to find out reasons to feed the baby and not reasons not to feed the baby. There are certain nutritional care bundles which we all should practice in our NICUs to reduce time to full feed, to achieve early full feeds, in turn early oral feeds and early discharge. So in our case, early exposure to colostrum, early trophic feeds, early progressive enteral feeds, standardized feeding protocol rather than feeding protocol based on our judgment, early stopping of antibiotics while culture are sterile and baby is doing clinically well, exposing to probiotics rather than antibiotics, early receiving full RT feeding, and early time to oral feeds, involvement of mother, early KMC, non-nutritive sucking. These all factors which we can consider as an enteral nutrition bundle, they can achieve early NICU discharge and early and good better neonatal outcomes. So there are certain evidence-based strategies to reduce NEC. NEC is a major morbidity uh, amounting for high NICU costs. They are human milk, use of 100% human milk diet, early trophic feeds, standardized feeding regimes, use of probiotics, and lesser use of antibiotics. These all standard protocol of nutrition helps in reaching early time to full feeds, better weight gain, less parenteral nutrition, less hospital acquired infections, and eventually lesser costs. So when we consider neonatal sepsis and practice variation for the same, there are a lot of variation in antibiotic use as well as its duration for suspected sepsis. And these all affect overall hospital stay for preterm and low birth weight babies. So this study, which compared 48 hours versus 7 days duration of antibiotics for suspected culture negative sepsis, it found no difference in the treatment failure rate. When we apply strict antibiotic stewardship protocols, it was found that antibiotic days can be reduced by nearly 100 days per year, and nearly 30% reduction in antibiotic use can be achieved with strict antibiotic stewardship protocols. So when we consider antibiotics and cost reduction, certain measures are no prophylactic antibiotic, early stopping of antibiotic in case of probable sepsis. When it is proven but uncomplicated sepsis, evidence says that 10 days of antibiotics are also safe, and strict pharmacy policies should be followed to reduce antibiotic use and eventually cost reduction. Early discharge is very important intervention which can help us not only reduce NICU bills, but it also helps families by reducing cost for visiting travel. It also helps in reducing overall time off work which parents takes, and by that reduces overall burden to the society. And it is an evidence-based intervention when a randomized control trial compared a control arm of discharge at 2,200 grams with early discharge policy. It was observed that early discharge group reduced NICU cost by nearly 27 to 30%, We are lucky enough that we discharge newborns in our Indian hospital setups at relatively lower birth weight, lower discharge weight, nearly 1400-1500 grams. However, we should also try to find out that how these babies are doing post discharge, and there are no readmissions. For that, we need to stick to frequent follow-up and home-based visits. So this interesting paper from Dr. Sharma and Dr. Murthy's group, which compared kangaroo ward care with intermediate intensive care in stable, very low birth weight babies. It was found that kangaroo ward care nearly reduces NICU cost by nearly 33,000 rupees. So we can also consider such kind of practice in our setup. Suppose we are having a 15-bedded NICU, we can consider designing a 4 to 5 bed kangaroo care ward where mothers can nurse the babies who are growing and are on full feeds. Mothers can give RT feeding to babies. They can change diapers. They can help in all nursing stuff. One nurse can be designated over there for care of these babies. And this kind of family-centered care in our own setups can help us reduce neonatal morbidities and in turn reduce neonatal care costs. So by creating opportunities for parent empowerment and active parental participation, we can reduce overall stress of the parents, we can reduce length of stay, and it was also found that there were less readmissions with active parental involvement in neonatal care practice. So when we consider nurse and NICU economics, most of the time the goal of managing more babies with fewer nurses is a fundamental economic aim of most of the NICU management teams. However, we should also consider that can it be done without impinging on quality of newborn care, because appropriate nurse to patient ratio is very important in maintaining quality newborn care. High nursing provision ratio during NICU hospitalization is associated with a lower risk of a composite adverse outcome in very preterm infants. So when we consider appropriate nursing care, a proper nurse-patient ratio has to be maintained. And by the same time, we should also consider designating nurses in specific neonatal care. As for example, can we designate one nurse for as a neonatal nutritionist who can look after preparing of parenteral nutrition, who can also look after preparing enteral feeds? Are babies receiving appropriate amount of enteral feeds? Can they be graded up? Is standardized feeding regime being followed? Is probiotic added to the feeds? Such interventions can overall help to reduce NICU costs, and it also help in reducing nursing workload. So NICU collaborative steps and quality improve project, they have shown to be potentially good practices to reduce infections, to reduce chronic lung disease. So we can collaborate among us NICUs where we exchange our good ideas and good NICU practice that we follow in our NICUs. Such kind of collaboration have shown to be quality improve, and such quality improvement efforts, they have shown to be helpful in reducing overall NICU costs. So points to remember: quality and cost go hand in hand. Evidence-based protocol and quality improvement project, they are key to cost reduction, and collaboration among NICUs helps in reducing overall morbidity, and by and large it helps in reducing NICU stay and costs. Thank you. Over to you, Anitha, ma'am.
Yes, thank you, Dwayne. Am I audible?
Yes, ma'am, you are audible, ma'am.
Okay. Can I share my screen now? Yeah, you have to stop sharing, I think.
Yeah, yeah.
Hello there. Hel-
Yes, sir.
Hello. So we'll take
Yeah,
the
yes,
questions
sir.
at the end in the chat box. Now,
Okay, sir.
can we request Dr. Anitha to take over?
Yes, sir. Yeah. I'm just
Yeah,
sharing
so
my
your
screen.
comments, I think, will make a lot of difference when it comes to how we can optimize the newborn care,
Yes, sir.
because your experience would help the private sector to optimize the healthcare and minimize the cost and give good quality care.
Yes, sir.
Yeah,
Yeah,
thank
thank you,
you.
sir. So, first of all, I would thank Sandeep Kadam, sir, for giving this opportunity to talk on this forum. So, as they has already given us a current perspective of the cost-effective approach in the neonatal sector in low and middle-income countries like India. So, my topic is just to brief you about the public sector perspective. Is my slides visible?
They are opening, madam. Their slides are not yet
Okay.
seen. We can see your desktop or laptop, but we can't see the slides.
Is it?
I think, ma'am, you need to share the screen which is having the slides. There are multiple. There would be multiple screens in your
There you have
this
stopped
Zoom.
sharing, na?
Yes, sir. I have stopped sharing.
I will share again. 1 second. Is it visible now? No.
Not yet, madam.
Oh my goodness.
Hello.
Hello.
Yes, ma'am. Can you first close, stop slide sharing? First, you open your PPT and then can you share your slides?
Okay, I'll do that. Actually, my PPT is already open only.
Then you can
Acha,
directly
okay.
click on the slides, madam, on that folder.
I don't know.
When we select share screen, ma'am, they will ask us which screen we want to share.
Yeah.
So don't go on
So
your
in
main screen. Go on your slides, PPT slides.
Okay.
slides.
Yeah. Is it seen now?
Ah,
Yes,
yeah.
ma'am. Yes.
Oh,
Perfect.
thank God. Sorry. Yeah. So coming to the topic, shall I start now?
Yes, madam.
So cost-effective approach in neonatal care, public sector perspective. So current status in public sector, we can see that there is improved NICU care for sick neonates. Definitely, this is our inborn section of KEM NICU. So we cater service to sick preterm, extremely preterm infants as well. Also, we have ELBW infants, especially micropreemies, are successfully managed to some extent. Maybe 500, 600 grammars are a bit difficult, but any baby who is more than 600 grammars are getting discharged home with some morbidities though. Prolonged hospital stay due to premature status and related sickness. This is another issue. So what is the issue? So financial burden to the family and government. And there is risk of long-term poor neurological outcomes in these infants. So there are a lot of studies which has been done in low and middle income countries and also in developed countries. They has already given us the narration of what is the outcome of all these studies. So one Indian study by Narang et al, they have shown that average cost of NICU stay for a baby who is less than 1 kilo is around $3,800 US. While for babies who are between 1 to 1.25 kilos, their cost is around $2,000. And similarly, when the weight increases, the cost decreases. And the studies, there are a lot of other studies also. And there was another study which shows that average cost, that was in the developed country, that is in Britain, which was the cost is very huge. You know, it is 17,861 pounds. I just put this table to show that actually when compared to the developed countries, the cost is definitely less in the Indian scenario when average cost, overall cost is taken. But even with that, the cost is not affordable for many of them. And that's why public sector perspective is very important. And what is the cost for this increased expenditure? So first of all, there is higher intensity of care required. And there is increased duration of NICU stay. This is a panoramic view of our NICU. So there are around 12 beds in inborn section, which caters service to around 20 babies. You know, that is a common scenario in public sector. And issues faced are limited human resources, limited medical equipments and technologies, space constraints in the NICU, and social issues in the parents, not only the parents and also in the family. How can we tackle this crisis? That is the main question. Restrictive NICU admission policies. So you should triage these admissions because babies who are requiring short-term care, like those babies who are having born to mothers with diabetes, gestational diabetes, that is infant of diabetic mother, those with minor congenital anomalies, those babies who are at risk for early onset sepsis, those who require some assistance in birthing process. These are the babies normally we admit to the NICU for 1 or 2 days. Even these, if it is properly tackled in the labor room setup with a good newborn care team, it can be avoided as an NICU admission. And this will definitely help in tackling this crisis. Second point is reduction in ventilator use or duration of ventilation. So we all know that the current Cochrane and review and analysis with antenatal steroids, which is the current molecule of this this decade, and also surfactant therapy, which has definitely shown decreased CPAP use, decreased mechanical ventilation, and also decreased long-term complications. So these are the two main molecules which has helped a lot, in reducing the ventilator use and duration of ventilation, and also other complications associated with it, and thereby definitely decreasing the hospital-acquired infections and also NICU stay. Similarly, sick neonates, mechanical ventilation or CPAP. So some prefer CPAP over mechanical ventilation, but it is all varying practice style by different practitioners. But sick neonates definitely will need whatever care the baby needs. So that has to be practiced. There is no solution for that. As far as possible, advocate non-invasive ventilation strategies. And we all know that labor room CPAP has definitely helped in reducing the use of surfactant and also mechanical ventilation in babies. And it has already been published in EJM in 2008. And after that, even in our setup, labor room CPAP is being advocated. And it has helped in reducing the use of mechanical ventilation and also long-term hospital stay in babies, especially extremely preterm and also preterm babies. So this is the Cochrane review about the antenatal steroids, which I was talking about, by Roberts et al., which has already shown wonders in newborn babies. Similarly, another Cochrane review by Stevens et al. For early surfactant administration has also helped in long way in taking care of the preterm babies. So now coming to the next point, that is a biochemical or microbiological or pathological testing, so which is normally required in newborn babies on a day-to-day basis. So what we can do in that is that reduce the frequent blood testing. So for example, in our unit, we use transcutaneous bilirubinometer to reduce the need for serum bilirubin level monitoring. That is one thing we can use. It will reduce the number of blood sampling. Depend on the clinical assessment. So you have to depend on the clinical assessment to decide repeated testing. So instead of repeated testing, so we don't repeat, because we don't have in public sector, we don't have the micropipettes and microcapillary tubes to sample the blood. So a lot of blood sampling, happens on babies. So to avoid that, we depend on the clinical assessment, and the need for testing is decided as per the clinical assessment as well. That will help in reducing the number of testing being done on babies. Reduce frequent blood gas monitoring in stabilized ventilated babies. So there are transcutaneous CO2 monitors available, so which can be used so that frequent blood gas monitoring, capillary or venous blood gas monitoring can be avoided. This will help in reducing the cost in some extent. Then coming to the next point, which Diya has already explained about the antibiotic use. So avoid prolonged antibiotic use. We have to strictly adhere to the antibiotic stewardship policy, and avoid prophylactic antibiotic use. For example, mothers with premature rupture of membrane for prolonged duration, and the use of prophylactic antibiotics for that is currently not recommended as per the evidences. So that should be avoided. And short-term versus long-term antibiotic therapy. So in our public sector, what we find is the time taken to get the microbiological blood culture report is prolonged, more than 2 to 3 days. So we have made efforts so that the blood culture report is available early, in 3 to 4 days at the time we are getting currently. So that the antibiotic therapy that is given to the babies can be curtailed as early as possible. Similarly, prophylactic antifungal therapy, currently we are not recommending that. That is another point of concern, so we will skip that. And regular surveillance of NICU for infection control practices. It is another point which will help in deciding what antibiotic to be used. Antibiotic policy can be changed, so that the stewardship can be followed as far as possible. The next point is reduce blood transfusions. Prophylactic and therapeutic iron supplementation has definitely helped a lot in reducing the need for packed blood transfusions in babies. And also, though we are not using erythropoietin therapy in our unit, but even though it is costly, it will definitely pay way to reduce the number of packed cell transfusions to be used, and also definitely has got some benefits in neurodevelopmental outcome as well, though the recent evidence doesn't support it by Joule et al. So EPO is another therapy which can be used to reduce the blood transfusions. Restrict total parenteral nutrition usage. So this is another point, because TPN definitely is costly, and preparing under the laminar flow is another thing which is costly, and also the duration of TPN and associated complications definitely will pave the way for increased expenditure for the parents. So advocate early enteral feeding and fast advancement of feeds in very low birth weight infants. Even in extremely low birth weight infants, feed advancement may be cautious, but follow early feeding practice. Reduction in the daily practice, reduction in the use of ventilation, and daily practice style. How do you practice all this ventilatory circuit usage and all is another point which we have to deal with. So restrict daily use of change of ventilatory circuits that most of the units are doing. So what we can advocate is recycling of the ventilatory circuits. Similarly, recycling of the CPAP circuits, recycling of the caps, recycling of the interfaces that we are doing in our day-to-day practice in our NICU definitely has helped a lot in poor parents, because it will be not affordable for most of them. And also use the nesting. We use the same nesting for prolonged duration. For the same baby, we use the same nesting. Only thing is the polythene wrap which we cover, we change it. That is another point which can help in reducing the cost. So also one more point is daily total parenteral nutrition is currently done in many NICUs, which can be made to 48-hourly TPN, which will reduce the cost. Recycling other equipments. So this is another picture where we can see that our are daily autoclaved in our unit itself. So similarly, we can autoclave party spoon. We can also sterilize ambu bag, umbilical tray, which can be recycled. So recycling is another, recycling of the various equipments is another point which will help in reducing the cost in public sectors. Use indigenous devices. So for example, this is one of the picture which we can see that there are two babies who are nursed in the NICU and they are on Miracradle. So for because we get a lot of perinatal asphyxia. So for these babies, using Tecotherm won't be affordable for, because it is expensive. Around 15 lakhs is the cost for Tecotherm. Similarly, using that becomes difficult. So we can use Miracradle. So Miracradle is less expensive. It is actually 1/10 of the cost of Tecotherm, that is 1.5 lakhs. So which can be used in babies for giving hypothermia. Similarly, intravenous line fixation without arm pad. So this is one of the, we are not using currently arm pad. That is a splint, which we call in Indian scenario, for fixing the IV line. Most of the NICs have stopped using it. So we are also not using it. And we are just fixing the IV line with a, sticking, so that also can be reduced. That cost also can be reduced. So now poor availability of staffs. So staff nurses are actually a shortage. Actually, when you come to cost-effective practices, a lot of evidences say that the nurse-patient care ratio can be reduced. In our NICU, what factor we face is we don't have staff nurses inadequate, because we have one nurse for around 11 to 12 babies in one section. So for that, what we are following is involve mothers in routine newborn care. So mothers are taught how to change the clothing, clean the diapers. They are educated how to look at the saturation monitor as well by the residents and by the staff nurses. And they are also doing feeding of the babies. Even tube feeds are being done by the babies after being taught how to hold the tubes. Motivate mothers and staff nurses by frequent small education sessions. That will help a long way, because we have a weekly education sessions for the mothers. Our head of the department does it systematically, and that will help a long way in helping the mothers, to educate themselves and taking care of the babies. So this is, mothers also feed Vati spoon feeds in our NICUs, and we can see that there is a single nurse in the whole NICU. She will look after all the babies. It will be difficult for her to look after all the babies, so this is one solution that we can practice. Then coming to the next point, sepsis and hospital-acquired infections. Definitely, that is another emerging. It's a very prominent complications in our NICU. So practice strict hand hygiene. Strict NICU disinfection policies should be followed, and always follow early enteral feeding and also early aggressive feeding for babies who are very low birth weight infants. And as DA has already told about the bundle approach, CLAPSI, VAP, IV cannula, and nutrition bundles should be followed, so that there's less chance for hospital-acquired infections. And this is about our laminar flow. We prepare the IV fluids and all the TPN, total parenteral nutrition, under the laminar flow. That will also help in reducing the infection. And the one of the important points, which actually they has already told, is quality improvement initiatives. So in our unit, there are around 4 to 6 quality improvement initiatives running at the same time, so that it will help in promoting the nursing staff and resident doctors, also by involving the paramedical staffs in taking care of the NICs in a better way. And definitely teamwork plays a lot in improving in the neonatal care in both public and private sector as well. This is our NICU team. Then mothers on milk. So promote breastfeeding. So this is very important point, because this is possible if we are dedicated. So promote breastfeeding and mothers on milk policy. Human milk banking and use of pasteurized donor human milk over formula will help a long way, because formula feeding definitely is costly. So in our NICU, we are not advocating formula because the parents are not affording. So our strong human milk bank has helped a long way in giving pasteurized donor human milk to these preterm babies. and we definitely need dedicated staff nurses and doctors for the same. So we do quality initiative projects in human milk banking as well. So that will also help in sustaining the milk banking. Promote hand expression of breast milk. So instead of using, we have got pumps, we have got electric pumps, but we advocate mothers to do hand expression. This also helps, to reduce the use of devices, because in a lot of mothers, there are 70 mothers in one ICU with 40 beds. It is very difficult for using machines. So hand expression has played a lot in sustaining the human milk bank and also for feeding these babies. And use indigenous pasteurizer of sophisticated devices. So we have a shaker water bath, which is used for a long time, for more than a decade in our NICU, and it is really useful. The next, coming to the most important point, is shortening the length of NICU stay. So discharge criteria for preterm babies. Currently, the discharge criteria, as said, is more than 1.8 kilo, more than 35 to 36 weeks, is not followed in our public sectors. So we discharge the babies when the weight is around more than 1.3 kilogram, and babies maintaining temperature, babies accepting feeds, mother is confident, and caffeine is stopped for more than 4 to 5 days and free of apnea. Then baby is getting discharged. So the discharge criteria has been modified, and there are evidences which show that, even in Indian evidence show that when the discharge is more than 1.3 kilogram, then babies do well. So our discharge criteria is 1.3 kilogram or more. So that has also helped in reducing the hospital stay. And practice kangaroo mother care. So in our NICU, we allow both mother and father. So currently, in the night sessions, my fathers also help in kangaroo mother care. Any relative can be given. So that also helps in early discharge of the babies. That is evidence proven. And also Cochrane review recommended oil massage. So we are not currently following oil massage therapy, but it is already proven that oil massage therapy to preterm and term babies helps in weight gain and also in early discharge. So that can also be done. And space constraints is the main overflowing admission rate. So we can see that there are 3 babies in our cradle. This is not to tell that the 3 babies kept in one cradle will reduce expenditure. Basically, it is tell that this will increase the chance for cross infection. It should be reduced. For that purpose only, we are discharging the babies at a early rate to reduce the number of babies getting infected. The next point is transfer back to community hospitals for convalescing neonates. Some of the neonates, their parents come from faraway places, and if the baby is just on feeding, just for the feeding establishment, babies be getting, for the preterm growth, babies getting admitted, then definitely as close to community hospital, the baby can be transferred. So this will help in reducing the NICU stay. It will be helpful for the parents as well. And this will also help the community doctors to maintain their skills, and and parental travel time can also be reduced. And one of the important point is follow-up. So strict OPD follow, because we are discharging the babies, preterm babies early. That doesn't mean that they go home and just like that. We call them in 48 hours time, and to our kangaroo mother care center, which is the developmental and also neonatology follow-up center, where babies are followed up, and there are doctors, nurses, trained doctors and nurses who sees these babies and allow them to feed also there, and this will help a long way in giving confidence to the parents and also in growth of the babies. And during these sessions, follow-up sessions, the parents are reinforced regarding the neonatal care. So this will also help in reducing the cost expenditure to the parents as well by reducing the NICU stay. And practice developmentally supportive care. This will also help a long way in developmental programs of the babies, development of the babies. So we can see that the nesting. So as I told you, our nesting, we use the same nesting for the baby as long as the baby stays, but we just wrap the poly drape, and this is being changed, not the nesting. You can see a mother giving kangaroo mother care in our NICU. Recent pictures. Now, next important point is counseling. So antenatal counseling of the parents, we normally give in birth defect clinic. So we have got a birth defect clinic where all the mothers who are having preterm babies and especially anomalous babies, congenital anomalous babies, they are counseled by a team of neonatologists and also pediatric surgeons. Sometimes obstetricians are also part of it. And this has helped a long way because then they come to know whether this pregnancy has to be continued or not because of the complications, and also helps in preparing the parents for the economic expenditure, because in our setup the parents are not affording, in many cases they have social issues. So this has helped a long way in in helping them to understand the birthing process and the need for NICUs. And also the parents are educated during these OPD sessions regarding the government schemes. So sometimes we all know that there are government schemes, so the parents are not aware about it. So which is already been done in these parents during their OPD visit. Then neonatal transport. So definitely prefer in utero transport, because if you think of transferring a baby, an outborn baby to NICU, because we don't have in public sectors, we means of public sector don't have a transport neonatal transport team to go to far off place and fetch the babies. So as in private sectors. So the parents have to take their own expenditure and come from far off places for preterm and also those babies with the congenital anomalies. So if these are being found in the in utero period as well, so if the in utero transfer is done, that will help the parents in a long way. Because, psychologically, it will help in reducing their stress, and also economically, because the transfer also is expensive. And train community level doctors to use CPAP in NICU. So this is another point which I've seen in the from the recent evidences. If the community, so in our NICU, we have got a facility-based newborn care program. So in this program, we train the doctors and nurses who are from different parts of India, not only from Maharashtra, from India. So they have been trained how to use CPAP in NICU for babies who are living respiratory distress, and they can use CPAP in the NICU. This will reduce the number of transfers to the tertiary care centers and further expenditure of the babies. This will also help in train the doctors also to use CPAP. So CPAP is easy to use, so that is being done. So that also has helped a long way in reducing the expenditure. The last is government programs. So we all know about the government programs. So one is the Janani Shishu Suraksha Karikram, and second is the Mahatma Jyotiba Phule Jan Arogya Yojana. So currently in our hospital in CGS Medical College, we have got these two programs running. So the JSSK scheme is free of free service for the mothers and babies as long as they are staying in the NICU. And MJPTV scheme is also available. So this has helped in reducing the expenditure in the parents. So key points of the talk is that prevent preterm birth. That is the main thing. So for that we have the surfactant and also the not surfactant, antenatal steroid, which is being used, and selective use of surfactant. Prevent mechanical ventilation. Prevent late onset sepsis. Early discharge criteria. And promote mothers on milk and kangaroo mother care. And the last point is counseling of the parents. This will help a long way in reducing the cost expenditure in public sector as well. Thank you.
Excellent presentation, madam.
Thank you so much.
Dr. Dea and Dr. Anitha, I think you have done wonderful presentation. Well, lots to learn, and I'm sure we all have learned a lot already. There are a few comments and some questions, so I'll just read and then we can take the final word.
Okay.
Nice presentation, Dr. Dea. A query: why would any hospital think of reducing the cost of care? What are the advantages to private hospital? Are there any conflicts of interest?
So, sir,
yeah, Amol is in Aurangabad, if I'm not wrong. He is at he's a faculty at Government Medical College. So
yes, sir.
Wonderful comment and question.
Very true, sir. Yes, sir. So, sir, working in the private sector, and since we are linked
to earn more money, why do you think they will think of reducing the cost?
Sir, basically, as a practicing neonatologist, we are the link between patients and management or private hospitals. So, more so ever, it is a responsibility of ours to make sure that we provide better quality of care at affordable price and
Correct.
relatively low cost. And we need to pursue for the same with, and we need to ask for for this purpose we need to bargain with our management, and we need to make sure that our
So I
patient
think we need
gets
to make it more cost efficacious and cost
very
effective
true,
and
sir.
not expensive. And I'm sure
Very
all of us are working for the well-being of the newborns and not for well-being of anybody else. So there is no question of inflating the cost, but we all should strive to give good quality care at affordable price. And I think Amol, I'm sure uh, since public sector you all are doing so much, in private sector it's our responsibility to do the same. In fact, Dr. Anitha, Amol has written that thank you for your lucid presentation. By restrictive admission policy, do you mean 30 babies in 30 beds or not to admit the 31st baby? How can it be made possible in a public sector, public health setting?
It is not possible.
Any
Yes.
any
Yeah.
supporting government resolution for this?
Currently, what one solution which we got in our setup is those babies who are in transitional care, those babies who are just for feeding and growing, they are kept close to the mothers. You know, there is a we have got a small 10-bedded space that is available in our labor room area. So where we are keeping those babies, you know, by that way the number of babies in the NICU can be reduced. But otherwise, overflowing babies will definitely come. Currently in our NICU also, we have 70 babies in 42 beds. So
So
that is
you
not
don't
possible.
refuse admission, or you do refuse admission?
We refuse admission. We are sometimes we refuse when there is no ventilation, because sometimes it happens that we don't have CPAP or ventilatory device or oxygen port available. Then in that case, we can't take a baby who's extremely preterm or
So,
preterm or 34 weeks.
so
So
level 3, I think we won't be able to take,
yeah,
and
otherwise
obviously level
preterm,
2
yeah, it
we
can be
may
kept near the baby.
address.
Yeah. So we can keep the babies near the mother if baby is level 2 care, those who are just for preterm and feeding and growing, they can be kept near the mother, so that burden can be reduced. That is the only
Uh,
solution.
Amol also wanted to know the experience of utilization of insurance in NSU. Is one more method to reduce the operating cost, I think, cost of care.
In our NIC setup, we are currently not, no parents are having insurance or anything. But if they come with insurance policies, they get, that also can be done. But we have the MGPJY and JSSK, so that is not coming into picture currently.
So there are multiple ways of looking at reducing the cost. In fact, we always thought that there was a myth whether expensive in terms of making it more expensive and inflating the cost versus providing good quality care. Do you think quality care is expensive, or in the net result will be that the child will go home early, so the cost of care will come down? So what is the paradox?
Actually, the thing is that the quality of care is very important. For that, we have to definitely, that will pave a long way for early discharge of the baby. So we should not be compromising on the quality of care. That will
Because
help
whenever we think that we want to give good quality care, we always think it is expensive, but actually it is a paradox. If you give good quality care, the patient will go home early and the net bills are going to be much lesser than providing a ordinary care and patient getting septic or nosocomial infection and the morbidity. So it's going to be tough.
Yes, sir.
One more comment for both of you. From Dr. Sudhir Mule, can we discharge VLBW babies on NGT feeding for feeding if the mother is well trained to give tube feeds? Either of you can take this, or both of you.
They can give any
Yes. Sir, as far as discharge is concerned, not only the mode of feeding, but also the other safety criteria like baby maintaining temperature on his or her own, parents
So
being
everything is okay. The baby can maintain temperature. The mother is confident. the mother can give tube feeds and she's willing to come for follow-up. So do you think we can send the babies home on tube feeding?
For that matter of fact, sir, actually we have sent certain babies who are not taking oral feedings. We have sent some babies on NGT feeding on discharge, but this cannot be considered a routine policy to send baby.
So there is some
However,
evidence. Yeah, Dr. Anitha, do you send home on tube feeds?
No, we can definitely send babies on tube feeds, but we are not practicing in our setup because of the social constraints of the parents. Sometimes it is not possible for the parents, but it definitely can be, definitely they can be discharged on it. It is not a, if mothers,
So I think
if mothers can be,
mothers can be taught and mothers can be trained.
Definitely, it can be done.
So it is not so difficult because especially the babies with HI stage, say stage 2 or in neonatal encephalopathies who want to be there, sometimes discharges are getting prolonged, or very small babies, the tube feeding can be given. Concluding remarks by both of you? There?
yes, sir. I would like to say that as we discussed earlier, less is more in neonatology, and in today's era where all costs related to healthcare, especially ICU cost and NICU cost, are increasing day by day. It is our very much duty of all practicing neonatologists to make sure that we give best quality care to our babies. We discharge them early, we follow up them frequently, so that overall we can provide better neonatal care.
Anitha, madam?
Yes, sir. So
Your
NICU care. So I think the quality of care can be improved by what I will tell in public sector perspective is motivating the parents, motivating the doctors, the resident doctors, and motivating the staff nurses is a priority. Because then only the NICU public sector we can give quality care for newborns. So for that we should always undertake quality initiative projects. And also, because awareness and counseling for the parents and also for the doctors. That is the take-home message I will give.
Yeah, so it's a teamwork, and we all need to strive to maintain that quality and send the babies home early. I think with this, if there are no more questions or comments, I am really grateful to both of you and all the participants. It was wonderful listening to you and there to have learned so many different perspectives. I think we need to see that our babies go home with good quality care and early discharge and safe discharge, I believe. So, and less invasive is more for these babies. So thank you one and all. Thank you so much on behalf of the Maharashtra State Element. Thank you, Irani Madam, for being here this evening. Thank you so much. Have a nice weekend. Thank you.
Good day, sir.